Welcome to a new IPOPI webinar on primary and secondary immunodeficiency crossover. Thank you all for taking the time to join this session. I am Martine Bergeon, IPOPI President, and it is my pleasure to moderate this webinar. Before we begin, I would like to take a moment to thank Takeda for making this webinar possible. Today, we will provide an overview on what are secondary immunodeficiency and how they are managed. We will also learn how SIDS differs from PIDs, what conditions lead to it, and what is their epidemiology. What to expect in terms of supply of IG will also be in analysis. To discuss this topic, we have invited Dr. Virgil Dalm. Dr. Dalm, you are an internist clinical immunologist in the Primary Immunodeficiency Center at Erasmus University Medical Center, Rotterdam, the Netherlands. Your clinical work focuses on care for adult patients with primary and secondary immunodeficiency disorders and transition care for adolescents with primary immunodeficiency disease. Your research projects address various primary immunodeficiency-related questions, from basic understanding of novel gene defects to identification and implementation of novel pathway targeted treatment strategy in clinical practices. Last but not least, you are a member of IPOPI advisory panel. Welcome, Dr. Dalm. How will this webinar work? Dr. Dalm will soon begin his presentation. When the presentation begins, you can post your question in the question tab that you see on the right side of your webinar screen. After the presentation, we will discuss a selection of questions with both Dr. Dalm and also with Dr. Silvia Sanchez-Ramon from Madrid, Spain, who is on the medical advisory panel as well. Dr. Sanchez-Ramon will also answer some of your questions in written form in the Q&A section on this webinar. Thank you, Dr. Sanchez-Ramon, for joining the webinar today. With introductions and explanations done, let's get started. Dr. Dalm, the floor is yours.
Thank you, Martine, and also thank you for this invitation to give this presentation for all of you. And today the topic indeed covers secondary immunodeficiencies. And actually, I would like to discuss what are the crossovers of primary immunodeficiencies and secondary immunodeficiencies. So, like already mentioned a few hundred years ago, it is primary immunodeficiency or secondary immunodeficiency, that's the question. So I want to show you today what can be the difficulties in differentiating between primary immunodeficiencies, secondary immunodeficiencies, but also trying to show how these things look like each other. Of course, needless to say, but very shortly, primary immunodeficiencies are generally very rare conditions. We recognize up till now over 430 inborn errors of immunity. They can affect the innate or the adaptive immune system. So primary immunodeficiencies are rare, they can affect all cell types, and their main hallmark of disease is recurrent infections. If we look at secondary immunodeficiencies, those are more frequent than primary immunodeficiencies. So primary immunodeficiencies are very rare, secondary immunodeficiencies are more common. They result from another condition, so they are not inborn like primary immunodeficiencies. They are the result of other underlying clinical conditions, and I will show you later in one of the slides. Again, secondary immunodeficiencies, like primary immunodeficiencies, can involve innate and adaptive immune system. So they can, again, involve all kinds of white blood cells. And again, like in primary immunodeficiencies, one of the hallmarks of disease is increased risk of infections. So you already see there are some differences between primary immunodeficiencies, but also a lot of similarities. So if we look at primary antibody deficiencies, to have a focus for today, because I said primary immunodeficiencies and secondary immunodeficiencies can affect all kinds of cells, but today I would like to focus on antibody deficiencies. Primary antibody deficiencies are characterized by low levels of immunoglobulins, disturbed response to immunization, so disturbed immunoglobulin function, and of course, recurrent infections. And as we all know, and this is just a picture depicting the situation in the Netherlands, around 60% of patients with a primary immunodeficiency suffer from antibody deficiency. So yes, it's clearly the most obvious primary immunodeficiency that we recognize. The prevalence of primary antibody deficiencies is estimated in around 1 to 1,200 individuals. Secondary antibody deficiencies are 30-fold more common than primary antibody deficiencies. So this is a very important difference. Primary antibody deficiencies are rare, while secondary antibody deficiencies are much more common than primary antibody deficiencies. So it's a clinical challenge because these diseases may look like each other. They may present with the common clinical symptoms. So I just want to introduce you one of my patients. This is a male patient, age 35 in 2014, and he was referred by the ear, nose, and throat specialist because of recurrent upper and lower respiratory tract infections. And this is an example of one of his x-rays showing an infiltrate in his right lungs. The question of the ear, nose, and throat doctor was, is there signs of an immunodeficiency? If you look at his medical history, in 2007, he had a cervical lymph node enlargement for which he was evaluated, and there was no conclusive diagnosis. 1 year later, a B-cell non-Hodgkin lymphoma was diagnosed with extensive lymph nodes and bone marrow involvement. So a hematological malignancy for which he was treated with rituximab, cyclophosphamide, vincristine, prednisone. So immunosuppressive therapy and chemotherapy. In 2009, he had partial remission, so he received additional treatment, again, with a combination of immunosuppressants and chemotherapy. And in 2010, he had complete remission of the hematological disease, and he underwent maintenance therapy with rituximab for 2 years. So when he presented in 2014, he was evaluated because of recurrent sinopulmonary tract infections. When you talk to this, when you saw him, the letter of the ear, nose, throat doctor described recurrent infections since 2012, so 2 years after the treatment, and he was recurrent culture positive for Haemophilus and Streptococcal pneumonia infections. But talking to the patient in the outpatient clinic, he had the feeling that he also suffered from recurrent upper respiratory tract infections at childhood. According to his mother, he was more frequently sick from school at that time, and there was a question whether he had indeed more use of antibiotics during childhood when compared to brother and sister. But this was actually still a question. These were the levels of IgG of the patient over the years. So you see completely on the left, 2008, he had immunoglobulin levels of 6.9 grams per liter, which was just below the lower limit of normal. And over the time, he showed lowered IgG levels. And when he was at our outpatient clinic, he had IgG levels of around 4 to 5 grams per liter. So developing hypogammaglobulinemia over time. Looking at more analysis at his level, so you see low levels of IgG in the upper red box, low levels of IgG, low levels of IgA, low levels of IgM. Going to the box below, all IgG subclasses were low. Going to the bar to the right, you see a disturbed response after immunization. So the first column of the right paragraph shows you that there is low levels of specific antibodies against Pneumococcus, Streptococcus pneumoniae. So what did we have? We had a patient with recurrent infections, upper and lower respiratory tract infections, with low levels of IgG, IgA, and IgM, a disturbed response to immunization. So what could it be? One, it could be a primary immunodeficiency, so a primary antibody deficiency with recurrent infections, as he mentioned, since childhood, and then presenting at age of 29 with a non-Hodgkin lymphoma. Or two, it could be a secondary antibody deficiency related to the underlying hematological malignancy that he was presenting with in 2008. Or it could be a secondary antibody deficiency after a treatment with immunosuppressives, like rituximab, which reduces the number of B cells, or it could be a combination of all or some of the above. So you see the clinical picture with recurrent infections, low IgG, disturbed response to immunization, could be either a primary antibody deficiency and then presenting at a later age with a lymphoma, or it could be a secondary antibody deficiency related to the hematological malignancy and or its treatment. So it's very difficult to make the distinguishment between those two. And again, like already presented in one of the first slides, secondary antibody deficiencies are more frequent, resulting from another condition. You see low levels of immunoglobulins, disturbed response to immunization, and indeed infection. So really resembling the clinical picture of a primary antibody deficiency. And this is a very nice picture that I took from a paper published by Dr. Patel and Professor Jols from 2 years ago. So which other conditions may result in an underlying or in a presentation with a secondary antibody deficiency? There are several conditions that give rise to an antibody deficiency. The important are hematological malignancies, the use and increasing use of immunosuppressants also give rise to antibody deficiencies, transplant patients that use immunosuppressants, or loss of antibodies. If you have an inflammatory bowel disease, you can lose immunoglobulins via this too. If you have severe kidney disease, you can lose proteins, including immunoglobulins, via the urine. So also loss of immunoglobulins may result in an antibody deficiency. So I just want to show you some examples. This is an overview what can all result into a secondary antibody deficiency, like also shown in the picture, and some examples I would discuss a bit more. So chronic lymphocytic leukemia, which is a hematological malignancy, and up to 85% of patients, hypogammaglobulinemia occurs. And even 25 to 50% of patients in this suffering from this condition die from an underlying infection. And hypogammaglobulinemia is worse in advanced stage of disease. So it's a very frequently occurring symptom or complication, so to speak, in this kind of leukemia. Very nicely shown already around 30 years ago is looking at the red bar. Patients with lower levels of immunoglobulins have more risk of severe infections. So people looking at the second table with low levels of immunoglobulins, so lower than 4 grams per liter, much higher risk of getting a severe infection, while the patients with CLL with higher levels of immunoglobulins do not have a increased risk of infections. So yes, they suffer from hypogammaglobulinemia, and the lower the levels of IgG, the more severe infections occur in these patients. The same holds true for other hematological malignancies. So CLL is a very important example, lymphoma, but also in multiple myeloma. Just a small figure to show the increasing number on the right side of the picture of infectious complications during disease progression. So yes, in hematological malignancy, low levels of IgG may occur, resulting in an increased risk of infections. But also the use of immunosuppressants and the increasing use of immunosuppressants is a very important factor in secondary antibody deficiency. And this is a picture already presented 20 years ago, that even in patients treated with high doses or long-term prednisone, you see over time, the higher the dose of prednisone on the x-axis, the lower levels of IgG. So prednisone, increasing dose of prednisone results in lower IgG, results in an increased risk of infection. So this is for classical immunosuppressant, but also a picture from the paper from Dr. Patel showing the increasing numbers of B-cell ablative therapies, so directed target and direct target therapy to the B cell, resulting in low numbers of B cells, resulting in low levels of immunoglobulins, resulting in an increased risk of infections. And over the next years, more and more of these kind of immunosuppressants will be brought to the market and will result in an increased number of patients with potential secondary antibody deficiency. So indeed, immunosuppressive therapy results in secondary antibody deficiency. And how is the clinical picture of these patients? Well, they suffer from recurrent infections, but this also is the case in primary antibody deficiencies. Also in secondary antibody deficiencies, you have patients with very mild disease, and in general, patients with renal loss of gastrointestinal tract, loss of antibodies, they lose their antibodies, but the antibodies they have in their system, they function normally, and in general, they have milder symptoms, while patients with hematological malignancy, or patients using immunosuppressants, they have indeed a decreased production, but also a decreased function of those antibodies. They suffer from more severe disease. What do you do when you suspect a patient of a secondary antibody deficiency? And this is taken from a paper from Dr. Sanchez Ramon, who's also in this webinar. If you look at the initial diagnosis or the initial evaluation of these kind of patients, it's more or less similar when you compare to the patient with a suspected primary antibody deficiency. You have to measure immunoglobulins, you have to perform potential B-cell subset analysis, perform a response to immunization. So the workup in a suspected secondary antibody deficiency patient is more or less comparable to patient with primary antibody deficiency. But what do we need? We need a kind of tools. How can we distinguish patients with primary antibody deficiency versus patients with secondary antibody deficiency? Because you want to know, is it indeed primary, is it secondary, and is there a suspected underlying hematological malignancy when a patient presents at your outpatient clinic? So there are a number of papers, and I just want to mention, I'm not going to in full detail today, but I think it's very important to find markers, biomarkers, specific things measuring in blood that can distinguish primary antibody deficiency versus secondary antibody deficiency. And there are a number of papers that discuss the use of class switch memory B cells or the numbers of CD4 positive follicular T cells to make distinguishment between primary and secondary antibody deficiency. So when to suspect? That's clear. How to diagnose? That is also comparable to primary antibody deficiency, but how to treat those patients. Patients with secondary antibody deficiency actually follow this more or less the same approach of primary antibody deficiency patients. Patients require vaccination, adequate treatment of infections with antibiotics in case of a suspected infection. Antibiotic prophylaxis can be considered. And of course, the question is, what is the role of immunoglobulin replacement therapy in these patients? So this was actually the first paper that was published in 1989 in blood in 12 patients having a hematological malignancy with secondary antibody deficiency who were treated with intravenous immunoglobulin replacement therapy. And there was a significant decline in the number and severity of infections. So actually this was the first paper showing efficacy or suggested efficacy of immunoglobulin replacement therapy in patients with secondary antibody deficiency related to an underlying hematological disease. This was quite an interesting paper, to my opinion, by the group of Isabella Quinti, in which they performed a survey amongst specialists all over the globe. How do you approach patients with a secondary antibody deficiency? And do not look at the specific numbers, but the message of this slide is that all specialists, I mean, there is not a good consensus between specialists how to treat patients with secondary antibody deficiency. So some treat early in the disease with antibiotics, some tend to treat early with immunoglobulins, others tend to treat a bit later. And if you look in literature, and this was a very nice survey by also Dr. Sanchez Ramon, who performed a systematic literature overview of the effects of immunoglobulin replacement therapy, there is not a consensus how and when to start immunoglobulin replacement therapy in these patients. If you look in the European medical advisory statements, when to start or when to initiate immunoglobulin replacement therapy in patients with secondary antibody deficiencies, these are the definitions. So these are for patients who suffer from severe or recurrent infections, who have ineffective antimicrobial treatment, and proven specific antibody function, or serum IgG levels below levels of 4 grams per liter. So these are the, let's say, the international advices when to administer immunoglobulin replacement therapy in patients with secondary antibody deficiency. So they have to fail on antibiotics. They should have a proven specific antibody deficiency or low levels of IgG. And this is that was the picture published in the paper from Professor Joles. Indeed, a diagram how to differ differentiate between the start of antibiotics and or start of immunoglobulin replacement therapy, and actually it follows the guidelines that I just mentioned, who developed by the AMA. So we see an increasing number of secondary antibody deficiencies, and it was also mentioned in this paper by Johan himself, together with Professor Jols, that indeed this is what we see in numbers of use of immunoglobulins worldwide. So over the time, every year, the demand of immunoglobulin replacement therapy is increasing. And if you see an increasing number of secondary antibody deficiencies related to hematological conditions and more related to the use of immunosuppressants. This is a table taken from the same paper and showing the situation in Australia. And you see all down that indeed acquired hypogammaglobulinemia, secondary antibody deficiency, gives the highest demand of use of immunoglobulin replacement therapy. More important than third bar from the bottom, than primary antibody deficiencies. So indeed, it gives an insight that there is an increasing demand for immunoglobulin replacement therapy in patients with secondary antibody deficiency. So what will that mean for the future? That there will be more demands on IgG supply, and we have to cope, we have to deal with that with our authorities and with our plasma producers. So with that, I would like to conclude this presentation, in which I try to show you briefly what are secondary antibody deficiencies. And very importantly, the number of patients with secondary antibody deficiencies is increasing because we can do more with immunosuppressive therapies. We treat more aggressively our hematological disease, so patients suffer from secondary antibody deficiency because of the treatment. The clinical picture is very comparable to primary antibody deficiencies. So these patients suffer from recurrent infections, upper, lower respiratory tract infections, bacteria who are the main sources of infection. Adequate diagnosis is very important to prevent complications and to initiate treatment. So when you suspect an antibody deficiency, perform the diagnosis, make the diagnosis, and consider treatment with antibiotics, consider a vaccination, consider the use of immunoglobulin replacement therapy. And with that, I would like to thank you for your attention and happy to answer any questions. Thank you.
Thank you, Dr. Dalm, for this interesting presentation with many learning points. Impressive to learn about the figures secondary antibody deficiencies being 30-fold more common than primary immunodeficiencies. Now we'll take some questions from the audience, and therefore I would like to invite Dr. Sanchez Ramon to join us on stage. Welcome back. You're there. Thank you to all for your question, and we have some of them. I will begin with the first one, which is there any precaution taken for patients who are treated with drugs, such as immunosuppressants, that increase the risk of developing a secondary immunodeficiency?
Yes.
So maybe you begin, Virgil, and Sylvia, you jump in when you think.
Yeah, so, well, yes. So in patients that we treat with specific immunosuppressive drugs, we tend to take precautions. A very famous example is when patients are treated with rituximab. Prior to starting rituximab, we tend to vaccinate patients to prevent them against streptococcal pneumonia infections, for instance. So yes, in specific conditions, in treatments with high risk, we take these precautions.
Okay, thank you. Sylvia, any words to add?
Yeah, great talk, Virgil. I want to congratulate you for this very practical, very clear. I wanted to ask you if it's possible, in our experience, about 20% of patients that are sent by the hematologist, hemato-oncologist, are suspect of having primary immune deficiency, as your patients that you have shown. But the problem is we cannot diagnose a primary after treatment. So do you have any estimation of in your series of patients with secondary, what is it about and what can we do? Because in our case, we do clinical exome, but if there is a mutation, okay. Your case was very, very, very low pneumococcal antibodies, but what can you do to try to improve that problem.
Thank you, Sylvia. Maybe Roger?
Yeah, that's a very important question, because indeed we would like to distinguish between secondary antibody deficiency or primary antibody deficiency. And a lot of patients that are referred by the hematologist, they underwent treatment, including rituximab. And those patients tend to have low numbers of B cells or complete absent numbers of B cells. And of course, for primary antibody deficiencies, we like to measure memory B cells as a marker of a primary antibody deficiency, which is not possible in those patients after rituximab therapy. In genetic diagnosis, yes, we can set the diagnosis, but otherwise it's very difficult. And indeed, there are some papers that now mention the use of peripheral blood mononuclear cell subsets to distinguish, but I mean, it's still a bit difficult to, in those patients presenting with a hematological disease after treatment, how to distinguish, it's quite difficult indeed.
Okay, we'll keep on the treatment, and I have a question, which is: do all steroids lower IgG levels? And if so, why are these prescribed for some PID patients? Roger?
Yeah, very, very difficult question. I mean, if you look at patients with primary antibody deficiencies, they, like common variable immunodeficiency as example, patients suffer from recurrent infections because of low IgG levels. On the other hand, patients with CVID have an increased risk of autoimmune disease, so autoimmune complications, also autoinflammatory conditions. And they tend to respond to the treatment with immunosuppressants. So in CVID, there's a balance, low levels, increased risk of infections, on the other hand, increased risk of autoimmunity. And you have to treat those patients, and you have to choose for prednisone. And then you take the risk indeed of lowering again the IgG levels. Yes, the difficult imbalancing in this complicated disease.
Okay, thank you. I have a question from Dr. Ciprian Giurcut from Romania. When the vaccination challenge with the evaluation of antibodies is recommended for the diagnosis of secondary antibody deficiencies, hematological malignancies, rituximab, corticosteroids, other immunosuppressants. So you can see the list in the chat, in the question tab, sorry.
We recommend to do it a diagnosis of the hematological malignancy. It could be the better moment, the better time to do that in order to distinguish, as Virgil has said, primary from secondary, even with that, not always. But it is important from a therapeutical point of view, as Virgil has, so prevention of infections afterwards and for diagnostic reasons. So a diagnosis.
Okay, and I have another question from Jutta Schoenauer. Thank you for this presentation, she says, but also why is it so important for you to differ between primary and secondary antibody deficiencies when the clinical presentation of the therapies are the same?
Yes, that's a very good question, because preparing this presentation, I was also thinking about that question, because indeed, if you look at the clinical presentation, there are a lot of similarities. If you look at the treatment, there are a lot of similarities. But I think one of the important reasons is that patients with a primary antibody deficiency versus secondary antibody deficiency have a difference in risk profiles for other complications. So I think in patients, let's say for primary antibody deficiency like CVID, you have a much higher risk of autoimmune complications and or autoinflammatory complications. So I think one of the importance in distinguishing between primary and secondary is the difference in risk of complications.
Mm-hmm. Thank you very much. We have another question about the treatment, rituximab, especially from Sofia Tantu. How long after discontinuation of rituximab, these cells or immunoglobulins turn to normal levels?
Yeah.
I don't know who will answer that.
Okay. Usually after rituximab, after 6 to 9 months, it begins to increase very slowly, and approximately at 9 to 1 year after the first dose can be normal numbers. when there are many cycles, it becomes more and more difficult, the reconstitution, and it depends on every patient. But more or less, after 1 year, we know if there is going to be a reconstitution of B cells.
Mm-hmm. Thank you. Thank you very much. Alvina Vidani is asking, do we have to screen for antibody deficiencies in all patients with hematological malignancies or patients with immunodeficiencies? Another Virgil?
Yeah, so if you look in, I've been discussing this issue also with the hematologists over here, because they see, of course, a lot of patients with antibody deficiency related to hematological disease and or the treatment, and a lot of patients do not suffer from severe infections. So the question is, should you evaluate all patients with hematological malignancy? I would say, well, only those patients who suffer from infectious complications, because the hematologist accepts that a number of patients get rituximab and get a hypogamma, but if they do not have infections, there is not always a need to treat, I would say.
Mm-hmm. Okay, thank you so much. I have another question from Anneli Larsson from Sweden. Have you seen that some immunosuppressive products affect the antibodies less than others? And if so, is it better for persons with primary immunodeficiency or antibody deficiency who also must take immunosuppressives for autoimmunity?
Yeah, absolutely. This is very important. And we are starting to learn how the new immunomodulators and that target B cells are impacting on the immune system. For example, ibrutinib is said to be really a big inducer of immune deficiency, while another treatments, for example, idelalisib, are less inducers of immune deficiency. So we have to choose always, depending on the individual patient, and try to do less harm always, of course. Mm-hmm. We have to learn a lot. We are just starting.
Okay, thank you so much. I will take another question. Is there any cooperation between different medical specialties to detect early warning signs for secondary immunodeficiencies? Virgil and Sylvia, maybe we will have each of you your word, because you are not in the same kind of country.
Yeah, exactly.
Oh, okay.
Well, of course, the history of infections is very important. So one serious infections, several recurrent infections, which is defined, as Dr. Jollis has published right now, as 3 infectious episodes in 1 year, or when the patient has autoimmune complications, thrombocytopenia, anemia, or other inflammatory complications. And of course, depending on the history, family history of immune deficiency, other comorbidities that may made immune deficiency, for example, diabetes, or for example, chronic diseases.
Okay, thank you. Virgil, a word on that, please? Would you elaborate?
No, I think I fully agree with what Sylvia says. Those are, I think, the common warning signs that should point toward a potential antibody deficiency or immunodeficiency secondary to other disease. Yes.
Mm-hmm. Another question about immunosuppressants coming from Judy Dragwell. Are there alternatives right now, or coming alternatives to immunosuppressants?
Yes. So, I mean, I think in general there are always increasing numbers of novel immunosuppressants or immunotherapies, and I think that, well, you always have to take the balance between what is the best therapy for, let's say, a very severe hematological malignancy, what is the additional risk of having a secondary antibody deficiency. So I think if you have a very severe disease, hematological disease, you have to choose for the best therapy for that patient, and then sometimes you have to take the risk that the patient develops a hypogamma including infections, and then you have to take the precautions like antibiotics and or immunoglobulin replacement therapy. But if you have, the opportunity to treat with alternatives, yes, it would be better to prevent antibody deficiencies. On the other hand, in patients with primary immunodeficiencies who suffer from autoimmune complications, you also have to take into account the risk of increasing the immunodeficiency if you treat with immunosuppressants, and you can choose for alternatives sometimes. But also there, if you have, for instance, a granulomatous disease, well, what we know until now, rituximab, prednisone, those are the therapies that seem to be most effective. And yes, they give an immunosuppressive effect and they give hypogamma. But if you have a severe condition, you have to treat aggressively and take into account that you may induce a more severe immunodeficiency, and then you have to act in treating or preventing that. But so yes, if you have alternatives, yes, but sometimes you have to treat with those kind of therapies that induce hypogamma.
Mm-hmm. Thank you. I think we will take this last question coming from Abaya Alawi. It's also an interesting one. Is it possible that the patient having secondary immunodeficiency has a genetic susceptibility to develop this condition?
Yeah, of course, as Virgil has very well said, it is very important to discriminate which patients of secondary immune deficiency could really be potential primaries, and try to do genetic studies on these patients. But I think we have to better define which group of patients could be, of course, as we have already said, with previous history of infections, as the case he has commented on. Well, when there is a clear suspicion of primary, we should do that.
Okay.
But yeah.
Virgil, would you have a word on that?
No, nothing to add. I mean, very clearly said, and fully agree. Yeah.
Okay. So I think that we come to the end of this webinar. I left a question from Egle Simulite, who is about, do you have any thought or insight on how to ensure security of IG or plasma supply, and be sure that IPOPI is working very hard on that. And all our efforts are really concentrated on this issue. It's a tough thing. Anyway, thank you to all of you for attending this IPOPI webinar. If you have a minute to spare, we encourage you to share your feedback on this webinar by pressing the link shared on the screen. The link will also be posted in the chat. Dr. Dalm and Dr. Sidaraman, I'm very happy and grateful for your participation in that. Thank you so much for this comprehensive webinar. Please note that you will all be able to see the recording on IPOPI TV within a couple of days. We encourage you to share it as much as you can to those who you think will benefit from it. See you next time. Please take care and keep safe. Bye-bye.
Thank you very much.